Glad you are here. Welcome to the official Global RPH YouTube channel. If you haven't already, hit that subscribe button to stay updated with our latest videos. Whether you're looking for medical insights, the latest healthcare trends, or fun educational content, there's something here for you. Vitamin B12 deficiency is a growing concern, especially among older adults. In the United States and the UK, it affects roughly 1 in 5 individuals over age 60, with over 26.5 million Americans impacted. A key contributor is pernicious anemia, which affects about 151 per 100,000 people in the United States. This condition can closely mimic Myelodysplastic Syndrome, or MDS, creating a significant diagnostic challenge due to overlapping clinical and laboratory features. Diagnosing pernicious anemia can be challenging, as patients often present with cytopenias that mirror MDS symptoms. This overlap becomes more complex when considering that anti-intrinsic factor antibodies can interfere with automated assays, consequently leading to misleading vitamin B12 levels that appear normal or even elevated. The implications of misdiagnosis are serious, as untreated pernicious anemia can cause irreversible neurological damage. Vitamin B12 plays a critical role in maintaining the integrity of the nervous system. When deficiency is left untreated, especially in cases of pernicious anemia, patients may develop progressive demyelination, and this can actually affect both the central and peripheral nervous systems. This can result in things like peripheral neuropathy, which might feel like numbness, tingling, or burning in the hands and feet. There's also a risk of loss of coordination or balance, also known as ataxia, as well as gait disturbances. Visual disturbances can occur too, due to optic nerve damage. It's important to note that these changes may become permanent if B12 supplementation is delayed. Now let's talk about cognitive impairment, specifically confusion and memory loss. Vitamin B12 deficiency is associated with neuropsychiatric manifestations, particularly in older adults. These may present subtly as forgetfulness, confusion, or difficulty concentrating, and can be easily mistaken for early dementia or just age-related cognitive decline. Without timely correction, these symptoms may progress to more severe forms of cognitive dysfunction, including short-term memory loss, impaired executive function, and disorientation. The good news is, timely B12 therapy can reverse many of these symptoms, especially when it's initiated early. There is growing evidence linking vitamin B12 deficiency to mood disorders, including depression and irritability. This is believed to be due to disrupted synthesis of neurotransmitters such as serotonin and dopamine. In clinical practice, patients may present with affective flattening apathy or social withdrawal and depressive episodes that do not respond well to typical antidepressants until vitamin B12 levels are corrected. Recognizing the role of B12 in mood regulation can prevent unnecessary psychiatric interventions and improve quality of life. If untreated, pernicious anemia can lead to severe hematologic manifestations, including pancytopenia, which means simultaneous reductions in red blood cells, white blood cells, and platelets, severe macrocytic anemia with fatigue, pallor, and shortness of breath on exertion, hemolysis due to ineffective erythropoiesis, and destruction of red cell precursors within the bone marrow, and bone marrow suppression that can mimic features of marrow failure syndromes, such as Myelodysplastic syndromes. In advanced cases, the bone marrow may show marked dysplasia and cellular changes that are difficult to distinguish from hematologic malignancies, increasing the risk of misdiagnosis and inappropriate management. The accurate diagnosis of pernicious anemia requires careful evaluation of megaloblastic hemopoiesis, vitamin B12 deficiency, and gastric intrinsic factor levels, parameters that demand precise clinical assessment to differentiate from true myelodysplastic syndromes. Distinguishing between myelodysplastic syndrome and vitamin B12 deficiency presents a formidable challenge for clinicians. Both conditions share overlapping features that can lead to diagnostic confusion, especially in elderly patients who typically present with similar clinical manifestations. Pancytopenia serves as a common hematological finding in both myelodysplastic syndromes and severe vitamin B12 deficiency. Interestingly, B12 deficiency can actually lead to bone marrow failure and dysplasia, resulting in severe pancytopenia, even without the typical neurological symptoms that we usually associate with this condition. Furthermore, in both conditions, the median age of presentation is pretty similar, right around 70 years old, with patients often coming in with insidious onset fatigue and shortness of breath. This age-related overlap makes the initial clinical assessment even more challenging and can delay a proper diagnosis. The morphological similarities between these conditions represent a major diagnostic challenge. For example, B12 deficiency causes stunted hematopoiesis, which leads to the production of large, abnormally nucleated red blood cells that can really mimic the dysplastic cells seen in myelodysplastic syndromes. In severe cases of pernicious anemia, you might see packed, dysmorphic erythroblasts that resemble certain leukemias, such as erythroleukemia. And on peripheral blood smear, findings in both conditions may include hypersegmented neutrophils, teardrop cells, and dysplastic white blood cells. In this context, serum vitamin B12 levels alone are considered an unreliable indicator in laboratory testing. Up to 50% of patients with subclinical B12 deficiency may actually have falsely normal results, especially when anti-intrinsic factor antibodies interfere with automated assays. To improve diagnostic accuracy, clinicians really should assess methylmalonic acid and homocysteine levels. Elevated levels of both are 99.8% sensitive for functional B12 deficiency, even when serum B12 appears within range. Now, how often is MDS misdiagnosed due to B12 deficiency? Although precise rates are unclear, misdiagnosis of MDS due to unrecognized B12 deficiency is increasingly reported. Studies suggest that up to 15% of hospitalized patients with unexplained cytopenias or macrocytosis are eventually diagnosed with MDS. Yet, some of these cases may actually represent treatable B12 deficiency. The impact of misdiagnosis includes unnecessary emotional burden on patients, inappropriate use of therapies like hypomethylating agents, and delayed treatment of a reversible condition that, if left unaddressed, can cause irreversible neurological damage, cognitive decline, depression, and progressive hematologic complications. Laboratory findings provide key differentiation points between pernicious anemia and MDS. Accurate interpretation really requires understanding the limitations and strengths of various diagnostic approaches. Serum vitamin B12 levels are commonly ordered but can be misleading. In patients with pernicious anemia, the presence of anti-intrinsic factor antibodies can interfere with immunoassays, especially chemiluminescent platforms, leading to falsely normal or even elevated values. Case reports illustrate how B12 levels may appear within the normal range, for example, around 490 picograms per milliliter, while a secondary assay reveals a severe deficiency, for example, 79 picograms per milliliter. Up to 50% of patients with early or subclinical B12 deficiency may actually present with normal serum levels. Clinicians should be cautious when interpreting B12 levels in isolation, especially in symptomatic individuals or those with hematologic abnormalities. Methylmalonic acid, or MMA, and homocysteine levels offer greater sensitivity and specificity by measuring tissue-level activity of cobalamin. Both markers typically rise in B12 deficiency, even when serum levels appear adequate. And when both are elevated, the sensitivity for detecting functional B12 deficiency reaches over 99%. There are a few clinical considerations to keep in mind. MMA may be falsely elevated in renal insufficiency, but usually to a milder extent. Reference ranges actually vary across laboratories and should be age-adjusted. Because homocysteine can also be elevated in folate deficiency, interpretation should take folate status into account. These tests are essential in ambiguous cases and are particularly useful in elderly patients or those with confounding conditions. Cytogenetic abnormalities can actually be classified as either transient or persistent. Vitamin B12 deficiency may cause chromosomal instability because of impaired DNA synthesis, and this can lead to reversible cytogenetic changes. There have been documented cases of temporary abnormalities, like a deletion on the short arm of chromosome 3 or del3p, that resolved completely after B12 repletion. In contrast, persistent or progressive cytogenetic findings, especially those involving complex karyotypes, are more characteristic of true myelodysplastic syndromes, MDS. Therefore, repeating cytogenetic analysis after correcting vitamin B12 levels is essential in cases with ambiguous presentations. Additionally, interpretation of bone marrow biopsy findings presents its own diagnostic challenges. The findings often overlap significantly between these conditions. For example, bone marrow in B12 deficiency can show megaloblastic changes, hypercellularity, dysplastic erythroid precursors, and occasionally increased blasts. These features closely resemble what we see in MDS, making it pretty difficult to distinguish between the two based on morphology alone. To complicate things further, markers like CD163, which are commonly expressed in the monocytic lineage, can also overlap with chronic monocytic leukemia, or CMML. Follow-up marrow examination after B12 correction often shows complete resolution of dysplasia, and that really helps confirm a nutritional rather than a neoplastic cause. The molecular mechanisms behind vitamin B12 deficiency actually create room for misdiagnosis as myelodysplastic syndrome. At the cellular level, several key disruptions occur that manifest as hematological abnormalities, and these can look strikingly similar to what we see in true malignancy. The fundamental issue in vitamin B12 deficiency centers on impaired DNA synthesis. Vitamin B12 is a cofactor for methionine synthase, which catalyzes the conversion of 5-methyltetrahydrofolate to tetrahydrofolate. In deficiency, this process stalls, creating what's called the methylfolate trap, which inhibits thymidine synthesis and impairs DNA replication. This leads to a decrease in de novo thymidylate, or DTMP, biosynthesis capacity by about 5 to 35%, while purine synthesis actually remains unaffected. You also see an increase in DNA double-strand breaks, as evidenced by elevated phosphorylated histone H2AX, or gamma H2AX. Chromosomal abnormalities in DNA strand breaks occur due to genome instability. This trapped 5-methyl-THF prevents formation of other folate coenzymes needed for DNA synthesis. Interestingly, the nucleus proves highly sensitive to 5-methyl-THF accumulation, despite this compound being synthesized in the cytosol. This nuclear sensitivity creates distinct cellular abnormalities that can actually mimic malignancy. Vitamin B12 deficiency causes asynchrony between nuclear and cytoplasmic maturation in hematopoietic cells. This asynchrony manifests as giant metamyelocytes and bands in the bone marrow hypersegmented neutrophils in peripheral blood and macrocytic red blood cells with aberrant nuclear development. During hematopoiesis, cells accumulate in S phase since the G2 to M transition just can't be completed without adequate THF pools. Consequently, the bone marrow becomes hypercellular with giant bands and proerythroblasts. In severe cases, these megaloblastic changes can be indistinguishable from myelodysplastic syndromes or even acute leukemia. Unlike true MDS, these cytogenetic and morphological abnormalities completely resolve with vitamin B12 supplementation. This reversibility serves as a crucial differentiating factor between nutritional deficiency and malignant processes. In cases where MDS is suspected, yet cytogenetic findings appear atypical, B12 deficiency should be conclusively ruled out through comprehensive testing before confirming an MDS diagnosis. Proper differentiation between B12 and iron deficiency anemias offers valuable insights when evaluating potential MDS cases. Understanding their distinct hematologic signatures helps clinicians avoid misclassification and inappropriate treatment protocols. B12 deficiency primarily results in macrocytic anemia with distinctly enlarged red blood cells, mean corpuscular volume greater than or equal to 100 femtoliters, whereas iron deficiency produces microcytic anemia with smaller than normal cells, with mean corpuscular volume less than 80 femtoliters. B12 deficient red blood cells appear oval-shaped rather than round, and you'll often see those characteristic macroovalocytes in the peripheral blood. Importantly, concurrent B12 and iron deficiencies may yield normal mean corpuscular volume values, which can create a misleading picture since the macrocytic effect of B12 deficiency can mask the microcytic effect of iron deficiency. Reticulocyte counts remain low in both conditions, indicating ineffective erythropoiesis. Yet, iron-deficient cells typically display hypochromia, that's reduced hemoglobin concentration, a feature that's absent in B12 deficiency. When we compare these conditions, the neurological presentation really marks a fundamental distinction. Vitamin B12 deficiency frequently causes things like paresthesia, gait instability, cognitive impairment or memory loss, visual disturbances, and sometimes mood changes, such as depression or irritability. On the other hand, iron deficiency typically lacks these neurological symptoms. This difference is actually explained by B12's essential role in myelin synthesis and stabilization. And B12 functions as a crucial coenzyme for methionine synthesis and methyl-malonyl-CoA conversion, which are both vital for neuronal health. That's why early diagnosis of B12 deficiency is so important, because unfortunately, prolonged deficiency can lead to irreversible neurological damage, even after blood counts return to normal with treatment. Hypersegmented neutrophils are a really valuable diagnostic marker. These are neutrophils with 6 or more nuclear lobes, or when more than 3% of neutrophils have at least 5 lobes. This finding actually demonstrates remarkable sensitivity, about 91%, compared to elevated MCV, which is only 62%, or RDW at 54%, in detecting B12 deficiency. Blood smear examination, specifically looking for hypersegmentation, is essential for screening B12 deficiency, since relying only on automated parameters like MCV can miss quite a few cases. Every now and then, hypersegmentation can show up in other conditions, such as uremia, certain medications, and surprisingly, even iron deficiency. But the pattern is just a bit different from what we see in classic B12 deficiency. To wrap things up, accurate differentiation between Myelodysplastic Syndrome and Pernicious Anemia remains crucial for optimal patient outcomes. Even though these conditions share overlapping clinical presentations, several key distinctions emerge through careful analysis. Laboratory findings, for example, require thorough interpretation, particularly given the limitations of standard B12 assays. Molecular mechanisms explain why B12 deficiency can actually mimic MDS at the cellular level. Neurological manifestations also serve as critical differentiating factors, and the reversibility of cytogenetic abnormalities after B12 supplementation really indicates a nutritional deficiency rather than true MDS. Maintaining high clinical suspicion and following a structured diagnostic approach can prevent unnecessary treatments for MDS and ensure timely correction of a fully reversible nutritional deficiency. In elderly patients, where both MDS and B12 deficiency are common, this distinction becomes even more important. Now let's move on to some frequently asked questions. Question 1. How can pernicious anemia be mistaken for myelodysplastic syndrome, or MDS? Well, pernicious anemia can mimic MDS due to similar hematological findings, including cytopenias and dysplastic features in blood cells. Both conditions often present with fatigue and shortness of breath, especially in older adults, making initial clinical assessment challenging. Question 2. What are the key laboratory findings that differentiate pernicious anemia from MDS? Well, while serum B12 tests can be misleading, elevated levels of methylmalonic acid and homocysteine are actually highly sensitive markers for B12 deficiency. Also, cytogenetic abnormalities in pernicious anemia are usually transient and resolve with B12 supplementation, which is different from what we see in MDS. Question 3. Why can vitamin B12 deficiency cause cellular changes that resemble MDS? Well, B12 deficiency disrupts DNA synthesis, leading to asynchrony between nuclear and cytoplasmic maturation in blood cells. This results in enlarged, abnormally nucleated cells that can be mistaken for the dysplastic cells seen in MDS. Question 4. How does the neurological presentation differ between B12 deficiency and iron deficiency anemia? B12 deficiency often causes neurological symptoms such as numbness, tingling in extremities, memory loss, and balance problems. These neurological manifestations are typically absent in iron deficiency anemia, providing a crucial differentiating factor. Question 5. What is the significance of hypersegmented neutrophils in diagnosing B12 deficiency? Hypersegmented neutrophils are a highly sensitive marker for B12 deficiency, with 91% sensitivity compared to other indicators. Their presence in a blood smear can be a valuable diagnostic clue, especially when other parameters like MCV may be misleading. Thanks for watching our Global RPH production. If you enjoyed the video and found it helpful, don't forget to smash that like button and subscribe to our brand new YouTube channel. We're bringing you a dynamic mix of content across a variety of topics, so there's always something fresh, engaging, and insightful just for you. Your support means the world to us. It helps us grow and keep delivering exciting, high-value content. So, stay tuned, because the best is yet to come.